Bruce. Thank you very much, Bruce. And hello, everyone. It's nice to come to one of the most beautiful places in the country. It's unfortunate that I have to catch a plane to go back, but it's been good. So I hope I do not destroy my welcome by this talk, that after this you will forgive me for the talk and give me a second chance to come back and visit you another time. So I'm putting a plug for a return visit. Again, I'm here on behalf of the wonderful people I work with and at Hampton and across the country in a number of initiatives. But really, this project in itself kind of, you know when something is right for you. Bruce mentioned a whole bunch of things that I've done, but I think this project, my main research that I do is in drug delivery and materials, and I love that stuff. I'm an engineer at heart, and those work has been primarily focused on applications in musculoskeletal biology. I'm an orthopedic surgeon by training and done some clinical work there, but has been mainly focused on research and education. So I'm going to talk to you about our Hampton University Regional Transdisciplinary Collaborative Center funded by the National Institute on Minority Health and Health Disparities. And it's a grant that we received in 2013, a 5-year award that's to address health disparities in minority male populations, and I'll tell you about that. Okay, so by way of getting into this topic, I know I'm dealing with a bunch of engineers, physicists, and hardcore, as Bruce used the word, hard science versus soft scientists. So this is by way of introduction to the soft science of epidemiology and public health. So if we were to look at different racial and ethnic populations in America, and we ask, well, what kills people? What do people die of? As an MD, we always write respiratory failure, which everyone fails of, but what caused the respiratory failure? And for all populations, it's usually heart disease and cancer. And you can look at, if you look at Caucasians, African-Americans, and Latinos, and Native Americans, I want to say, it's heart disease and cancer 1 and 2. And there are other groups, Asian Americans, Pacific Islanders, and Latinos, the order is switched. And those numbers may be changing as the demographics of the country changes, and you can talk about some of the reasons for that. But again, it's heart disease, and then you get to stroke and a number of other things. But we are usually dying of pretty much the same things, and in the sense that we are, in ways that we are alike. So heart disease and cancer kills us as the top 2 causes. Strokes is always there. But really the underlying cause for this is usually related to something that, if you live in California, you're not exposed to: unhealthy diet, because we all eat well in California, and you get lots of physical activity because you walk and you bike and you don't drive a car everywhere, and there's not very much tobacco smoking in California, and you probably don't drink alcohol unless you go to Mexico. So all of these things probably, I know I'm on a college campus, so okay. But this is very un-California, but very much common habits, bad habits all around the country, and leads to a number of things. But as much as we are the same, there are some differences that separate us. Okay? And the question is, what underlies those differences? And as we talk about the outcomes of disease, so some of the things you can see: chronic liver disease is much more common as a cause of death in Native Americans and Latinos. Homicides is a high cause of death in African Americans and Latino populations, and there's a low incidence, lower than other populations, of Alzheimer's disease in Native Americans and Latinos, and there are multiple reasons for that. Some of it can relate to biology or other factors that may affect these outcomes. So I thought as we start this, we should kind of put a historical context to this. So we are looking at racial and ethnic health disparities and how these things result in bad or disproportionate or unanticipated health outcomes. So, and, you know, after the civil rights, there were some things that was done that was put in place with the intent of improving the health of all groups, particularly those that have been historically disadvantaged in the American community. And this is a paper published by David Barton, who is he's at Temple University in Philadelphia, and it's published in 2005, and it says the civil rights era efforts to end disparities in health in federally financed, and again, it's only if you're financed by federal we can mandate laws to change behaviors and patterns. So if you're a healthcare system which is completely private, that doesn't use federal money, you can ignore all of the federal regulations and laws. But many of our tertiary medical centers are financed by Medicare or Medicaid, so that impacts them. They're faced with three successively more difficult challenges. One was to end the historical legacy of laws that prohibited people based on race or ethnicity from being given access to the same kind of care. And we all know about those. So those Jim Crow practices that segregated patient treatment by race. So we can do some things about that. The second point was to eliminate the more subtle forms of segregation shaped by physician referral practices. Again, also access to insurance, and also where you live. If I have to drive, if I get a stroke and I'm 3 hours from a stroke center, TPA doesn't benefit me because I can't get there in time, okay? And if there are no stroke centers located where I am, if I have such a stroke, the improvement in that area doesn't impact on my health outcome. And the last thing is assurance that once we can assume that we have equal access to care, okay, that these care is provided without any discriminatory practices. So this is the backdrop for when we look at the historical legacy of health disparities in the country, what we are faced with. And you can take this, we can change it from disparities in health, so we can talk about disparities in income, we can talk about disparities in education, and they're all one and the same, okay? And I'm not a sociologist. I did get a degree in physiology, biophysics, and engineering, so I guess it's the medical school training that prepares me to talk about sociology. So if we look at racial and ethnic differences in life expectancy, and we're going from, this plot looks at from 1970 up to 210, and this data, you know, you would have to be blind not to realize there's something going on here. What's the origin of it? So we look at Caucasian population, all races, and I wish I had on this, if I had the Latino, but the Latino data, because Hispanic as a category was, the CDC didn't have data on this prior to about the late 90s, early 2000, because Latino as a group was never demographically dated. So there was no data going back. So the Latino data would actually have a life expectancy, particularly for Latino women, which is higher than that of Caucasians in all categories. So Latinos, for being Latino, is a protection for longer life expectancy than any other group. So become a Latino, that would be helpful. But in lieu of that, you're stuck with the fact that there are these racial and ethnic groups that we belong to. But the underlying thing here is that there's this large gap that's decreased a little bit. In 40 years, maybe you've cut the gap in half. So if you were to extrapolate that slope, we will probably have to go another 40, 30 years before we eliminate the gap, and is that an acceptable rate of change? Okay? So there's clearly, by life expectancy, which is the sum of multiple things that we experience in our lifetime, there's a huge gap in just looking at African-American life expectancy versus that of the other groups in our community. And the question is, why is that? Is that a natural difference, or is that something artificially created? Okay? So if we were to ask the question, is this a health difference? The incident of low birth weight in men delivering babies versus women delivering babies is a natural difference. I expect there to be a difference because men do not deliver babies. That's a health difference. That's natural. But is that a disparity? Because I have a difference, does that make that difference that you see, is it a disparity? And that's really what we're going to look at. So if we just look at, we took a survey, this is CDC data, and they did a survey and asked a bunch of people, what do you tell me, self-reported, what's your standard of health? And if I was to ask Bruce, what's your standard of health? From your judgment today, you can say you are in excellent or very good health status. And we can do that based on how many medications I'm taking. You know, do I have any active disease processes going on? But, you know, and as you see along these, so it's excellent, good, or poor, and you look at the racial and ethnic self-reported quality of health, and non-Hispanic whites, blacks, Hispanic, all the way down to Native American, and you can see there are general differences in the self-reported quality of health. So if you decide, well, you're going to use a reference group, and we often pick the white population as a reference group, maybe only about 12% would report that they have poor health. But if you were to go look at the Hispanics and you ask them, nearly a third of them would say they have poor health. This is self-reported, okay, so it's a survey. And Native Americans would say about a quarter of them would say they have poor health. So if you're an Asian, you did better than on average, and statistically, you would think that fewer Asians have poor health. And that's in general aggregate. Okay, so are these health differences or are they health disparities? Because every difference is not a disparity. This one I thought was interesting. This look at the untreated dental caries. Okay, oral health. Okay, so this is looking at across the spectrum of development, so from 3 to 5, 6 to 9, or 13 to 15-year-old. So our kids growing up in your house. Okay? And it looks at ethnic groups, and it also does one other thing. It puts in socioeconomic status here, which is quite interesting. So we look at racial and ethnic differences, but socioeconomic. So if you are below the 100% federal poverty level, are you above it? So just look at that alone. Just look at the socioeconomic. So if you are above or below, the difference in incidence in this age group is huge. Is that a health difference or is that a health disparity? So you go up to the teenage, yes. Look at this. So if you are African American, 25% of those individuals would have a likelihood of dental caries. Why is that? And then there's a correlation, again, big difference with socioeconomic status across all age groups. So are those health differences or are they health disparities? So that's the get a definition. So if we look at populations with equal access to health care, so we normalize to that, so it's not in my insurance status or anything, and I look at a reference group, and we just call this the non-minority, but in the case it could be a minority that has the better health, because I showed you previously where Asian population in a given subset may be the better reference. So we have to think about what's our reference frame. But so this is common. So it's usually, in sense of looking at racial and ethnic differences, the non-minority population is usually the reference using it. And the minority population is usually with the less. The quality of health for that population is usually different. And that's the difference in this. And there are multiple things that contributes to that. One could be, at the bottom, it could be discriminatory practices. It could be access to healthcare system, the availability of it, whether you have insurance or not, the regulatory requirements, the fact that whether I can enforce or force the ACA has been tremendous in forcing health systems that really may not have had an interest in the community that around them to actually have to pay attention now because they're required every 3 years to do a community survey, a needs assessment. So if the community survey says they have a need, they have to respond to that by the federal regulations through ACA. Before they could have ignored the community. Now they have to go to them. So, and then it's the clinical appropriateness, it's the needs of the patient. I may have something and I refuse care. But so you have to take that can contribute to a difference, but it's not a disparity, it's a choice. So really, the total, many things contribute to difference. So when we talk about disparities, we are talking about a segment of the difference, not all of the difference. So let's give some definitions, okay? So what's the disparities? There are significant gaps or difference in the overall rates of disease, incidence, prevalence, morbidity, mortality, or survival in a given population compared with the health status of a reference population in a general sense, okay? Irene Banquet-Mullen happens to be my program official at the NIMHD for our grant, and she likes to coin it, and she says that in this paper that they published in 2010, it's the premature loss of life, increased burden of disease, and inadequate access to quality health care endured by health disparities population, the population that's disenfranchised. In fact, health disparities, she says, are rooted in social structure inequalities and exist because of inequitable distribution of goods, resources, power, and poverty in the American society. So that's the everyone, and I'm going to skip over that. So let's go to the more global view of this, because I know America is the center of the world, but it's not the whole world. What does the World Health Organization say about health disparities? This says it's a difference in health outcomes, as I've showed, which are not only unnecessary and avoidable, but are considered unfair and unjust. So this actually takes the whole discussion about health disparities to a social justice question. It's not just about difference in outcome, but is that inherently built into a system which is unjust and disproportionately burdening certain populations with adverse outcomes from disease processes. Okay. Did I go backwards? I think I did. Okay. So what are the determinants of health disparities? One of them could be place, and I thought this would be a good demonstration. These are CDC data looking at heart disease rates within the 2007 and 2009 in men or in age 35 by counties. And each little quadrant represents all the counties in America. And again, this is the age-adjusted death rates, annual death rates per 100,000. The darker it is, the higher the number. And you notice, where are you guys? You guys are right over here?
No, further south.
There?
Keep going. Down.
Where? Okay, so you guys are that little white spot. Okay, so whoever lives around you, they need to start moving into this area. Well, okay, I told you, okay, that Viking. So that's Irvine right there, and you have a very low death rate from heart disease. But as you notice, just in the California area, where you live seem to be impacting on your death rate. Okay, but really, the really dark spots, I'm not sure what's going on up there. And this is South Dakota or wherever it is. But you notice in this region, it's a really hot spot. And if I was to then take another census map and populate and do the distribution of African-Americans, where do you think the African-American lives? You're from there. Okay. But you can literally superimpose. And if I then take annual income socioeconomic status, guess where it overlays again?
Where's best barbecue?
Yes, the best barbecue to kill you. Okay. But anyway, but again, you can see place where you live. And it could be diet, but it could be other elements of that environment that's killing, that increases your burden. It could be the allocation of services. It could be a whole number of factors. Okay? So that's that. So look at, so then, and we talked about before, what are determinants? It could be who you are. Maybe it's your race or ethnicity. So this is looking at prostate cancer incidence from 1999 to 2011 and the incidence per 100,000. And again, the red is African American, and the blue and the green is Asian American and Alaskan Pacific Islanders. So these guys, they don't die. They don't, I don't know, they don't have prostates. I'm not sure what's going on. But it's really low incidence here. Again, so we can learn from this what's going on in this population, why their prostate cancer incidence is very low. Then you have the Latino and Caucasian. And then what's going on here? Is this related to biology? Is it genetics? Why the marked difference? So who you are. And again, if you look at the prostate cancer death rates, much tighter here, but what is going on here? Why are the rates so off the scale high for African American men dying of prostate cancer versus much lower rates, more than twice the rates in African American men? Is it their biology, or is there something else contributing to that? What's contributing to this difference, this disparity in outcomes? So the people in the health disparity world, and I've come to appreciate, is that health disparities are complex. There really are multiple factors and multiple levels of determinants. At the biological level, there's genetic and epigenetic factors. At a psychological level, behavioral, lifestyle, community, culture, individual choices, individual habits. Social, there's some political, environmental, economic factors which are contributing there. And it depends on who you are, whether you're a vulnerable population, based on race and ethnicity, your sex. And again, what you need to realize here is that when you talk about this disparity, you really have to talk about in which environment you're describing the disparity. Because what may contribute to a disparity or an unavoidable health outcome in one environment may not be the same in a different country. So the context, so who you are, the policies, the nature of the relationship between male and female, socioeconomic status, all of these factors, the age, whether you're looking at as I showed before, the dental caries, as where in your life cycle are you, okay? All that, and your geography. Are we looking at rural, urban, suburban? So we need to look at it in the context. So there are multiple factors. So this is really what makes this complex. You're trying to deal with problems, and it's, we are accustomed to using the reductionist approach. You control all the factors, you change one thing, and it works. This is likened to it's now we can call it the old days when we used to study signal transduction pathways. Way back when I was in grad school in the 80s and such, when people thought that if you understand the signal transduction pathway, you're going to solve every disease. And then we've got these maps with the signal transduction pathways and everything is connected. And so, oh my God. And that's the nature, the analog of what these kind of problems are, because there are multiple factors addressing them. So if you want to look at an operational model, and there's a conference that NIMHD puts on every 2 years, and people get together talking about these problems, and you can look at it, again, at the public health level, the individual level, at things that you can do to moderate those things, and then the final health outcome. And this can be social, environmental factors that could be controlled at the policy level. What's the legislation? I mentioned the ACA as being a major legislation that has impact on pretty much everyone in the community. That changes things. The environment, whether I'm in California, the air is nice and good around here, so you breathe lots of it, or you go to Beijing, or you go to someplace up in Colorado. So it does make a difference. The built environments, do we live in environments where there are sidewalks? bike paths on the streets for you to bike? Is that part of the built environment that allows you to cater to you living a more healthy lifestyle? And now you can go in the South where you have great barbecue and you're encouraged to eat, and that. So, and your exposure, the dosage. When do you get the exposure? Am I being exposed to alcohol with the high incidence of alcohol outlets in low-income areas, and intrauterine I'm exposed to alcohol? Am I exposed to the effects of alcohol that leads to increased crime, that increase my allostatic load of stress, that predisposes me to disease? So and how much of it am I exposed to? Okay? Is it a single dose? Is it multiple? Is it cumulative? And all of these things affects the biology, the life stage. I said, where are you in your life when you get it? And again, the individual factors. This is what we talk about. You know, are you a runner? Are you an exercise? Are you a discipline to do the healthy lifestyle or not? So these are individual choices. And then there are things which relates to the biology, the genomics. You know, my metabolic rate, my propensity, my biological background. That's all basically is the basis for which all of these things are being affected. And then there are modifiable factors here, where community, whether there's social systems, support systems, and access to care and other things. But ultimately, all of that combines to do this. So if I am looking at factors, and again, I just talked a little bit about that. So when we talk about using science, and the field that's developed is called health disparity science, we really want to develop progressive, we want to develop systems of approaches which lead to reduction in these disparities, and over the time this has been very slow. There's been a lot of money invested in this over the number of years, and tangible reduction in disparities. I showed you in the life outcome from 40 years, we've probably reduced the gap from 8-year difference between Caucasians and African-Americans to now about a 4-year difference in 40 years. So it's been very slow, but we haven't really been able to make the monumental changes we want. So in order to eliminate these, we need to come up with some new models and framework to do this. And we can take the standard approach. I showed you that there are multiple complex factors that's contributing to this disparity. So I can just study the cell biology of this, and I'm going to be able to reduce the death rate in Mississippi by just studying the cell biology and develop a drug that burns away fat. But am I going to be able to actually change the outcome of heart disease in Mississippi by simply doing that? Probably not. So there's been a strong advocacy for using collaborative research teams approaches to do this. And this is necessary because we need innovative and transformative approach and interventions that operate at multiple levels of the determinants of health disparities in order to impact on it. So we need a different approach than we've classically done in our approach. So this is one model that's been developed. This is a community-based participatory research model which is used to reduce health disparities. And this model, this is looking at, say, reducing heart disease, as I talked about in Mississippi. So if you wanted to do that, how would you really have to go about doing this? Yeah, we need to understand some of the biology. We need to understand what are the contributing factors in our diet, in our lifestyle that can really be adversely positively impact on the desired outcome. And we need to really reach the patient. So it requires the biologists, the sociologists, all of them interacting to get some input in, whether it's training community health workers, taking the science that you develop in the laboratory, translate it to the community. We can do some work with community members to begin to mobilize them to create the kind of Irvine effect, where you get creating a white spot instead of a very dark spot as far as high incidence. But in order for that to happen, you have to mobilize people to take the knowledge and apply it so that they change their lifestyle and change their ultimate outcome. And then again, you would do all the input. So these are typically academic community partnerships where researchers from an academic institution have to go and engage the community that they want to change their lifestyle and health outcome. And it's really hard work, you know. It's not just recruiting participants. You have to get them to be compliant and change their lifestyle to actually change something like their outcome in heart disease incidents. So these approaches and their short-term metrics that you can put in place, midterm, and ultimately we want to be able to do that. So CBPR is community-based participatory research, which is there's some principles developed there. That's one approach to doing this, and it's been applied in many cases with some impact usually in specific designated communities. So the inherent complexity of disparities in disease, such as cancer and cardiovascular disease, and the vast number of interacting causal mechanisms that fuel them requires new models to address this. And what's one of the new models? So this transdisciplinary, remember I told you our center is called the Transdisciplinary Collaborative Center. So this transdisciplinary collaborative process is an idea. Some of you may know there's a big push for team science. The physicists, when you see those publications in Nature or Science, it has like 90 people on it. That's a team science project. You have a lot of people contributing to a result. We haven't done that a lot. You know, the Human Genome Project was such a project, and I know Director Collins is a big pusher for this big science approach to solving challenging problems. So back in 1980, a then director of the NIH, actually in 2002, director of the NIH, advocated in the roadmap for the 21st century that we should adapt a more team science approach to solving some of the big, more complex problems. And I think you would agree by now that health disparities, because of maybe the definition of what those are, the multiple factors that contribute to them, represents a big problem that classical reductionist approach is probably not going to make a significant impact in solving. So this idea of building research teams that would have the flexibility to create and expand upon innovative collaborations among vastly different disciplines to encourage transdisciplinary work that integrates the behavioral, social, medical, biological sciences, thus providing new approaches to solving complex medical problems. And I think to be at Beckman, I think, is a model of where this happens, where you guys bring together people from across the disciplines, different background, working with from the basic science, the physical sciences, to the clinicians treating patients to address a number of medical issues. And really what we want to do is to adapt these kinds of approaches to address these complex medical problems as I described previously. Okay, again, it combines these expertise that span multiple levels of influence of health disparities, but the idea is that they will come together and develop a shared conceptual framework to deal with the problem. So really what transdisciplinary collaborative research efforts are aiming to do is to encourage people to come together and not do simply multidisciplinary, where we all address in cancer, but we all go off and do our separate thing, but to come up with unified, so any of the physicists, unified theory. So we want a unified theory for addressing these big problems. And how do we do it where we are working in an integrative manner so that your work that you do on the bench translated not just to the bedside, but to the policymakers who influences the society and the context in which you practice our healthcare. So these are the kind of approaches we are trying to come up with. So one of the things that we as an HBCU, historically black college and university, which Hampton University is, we asked the question, so where do we fit in all of this? As I showed you, African-American community is one of the communities which bears a tremendous adverse burden of disease outcome in many disease spectrums. So as an institution that historically were created to address issues in the black community, we felt that, you know, this was a crisis area that HBCUs as a collective and Hampton as a specific institution should see as a call-in area for us to address today, and how we can leverage our expertise, our insight and knowledge of our community to impact on their outcomes and maybe bring about a more rapid transition to eliminating these disparities that we are seeing. And that could be done in many different ways. Could we come up with innovative approaches that comes out of our milieu of where we are to address some of these? I showed you, many of these have to do with context, culture, habits, behavior, which are traditional science. If you're not connected to the community, you may not have a good insight into. So that was really the background for our interest in not leaving health disparities research, which has been left to really the big medical centers and the major predominantly white institutions are the major centers for health disparities research. University of Michigan, Ann Arbor is a major center. University of Alabama, Birmingham are big centers. UCSF has done many, and there are many other centers around the country who have done tremendous work. University of North Carolina, Chapel Hill, who have done a huge amount of work, but it's been primarily left there. Morehouse School of Medicine in Atlanta has done significant data, probably the major contributor from the historically black college and university community who's working on this, and there's some others, but we felt that there was opportunity here and a need for us to get involved in trying to do this. So that's why we jumped in. So what are we? So we're the Hampton University Regional Transdisciplinary Collaborative Center, and our interest is to look at research, education, training, and outreach, and really to affect a number of issues that we're concerned with. The vision of this was to nurture and leverage the research expertise within minority serving institutions in basically helping the NIH address this problem of health disparity, and to cultivate these interinstitutional partnerships within our community to really bring faculty members, train faculty members to help reduce these disparities, particularly in minority male populations. And by doing this would really enhance our capacity to compete more effectively for a lot of the NIH money that's out there to do that. And as you know, just a comparison, in total, HBCUs receive less than $500 million of federal dollars total in research and development and training across the country. In contrast, MGH alone receives about $350, $400 million each year. So your relative contribution, just one institution, but relatively, HBCUs have not been major players in receiving federal funding, not just from NIH, but NSF, DOD, DOE, to address a number of problems. So objective of the Minority Men's Health Initiative is, as I mentioned, to advance research, education, training, and outreach. And we decided to focus on minority men's health issues related to prostate cancer, melanoma in Hispanic population, cardiovascular disease, violence prevention, diabetes, and obesity. And our primary aim here is, again, to develop and provide transformative men's health disparities reduction models that could be sustained beyond when our funding goes, and transferable across multiple communities that are faced with these problems. So that's the charge that I'm given, and I hope you can help me deliver on some of these promises. So our structure as part of the grant, there's an administrative core, there's a research core where we hire new faculty hires to build capacity within the consortium. There's a collaborative research sub-projects core, which were the research projects around those disease areas that were the core of our proposal. We have a pilot project program, which really allows me to be very creative and gives us to bring in new ideas that we didn't think about when we initially did this. Collaborations and partnership core, which allows us to build relationship with other areas, other entities that can work towards our aim, and then we're supposed to disseminate these models and things we find either the usual publications so you can get renewal, but also hopefully translated into the community so lives are changed and habits are changed. So that's really what we are. So our collaborative projects, and how am I doing on time?
About 15 minutes.
Okay. Yeah, I'm going to quickly go through. So just to give you a sense, we had 4 primary projects, and again, the model here is along the diseases I mentioned, and the idea was to try to build inter-institutional collaborations between researchers at multiple institutions that we have. So there is a group at Clark Atlanta who's developing really a quality of life registry for prostate cancer patient, African-American prostate cancer, which doesn't exist. You figure in this day and age there would be one, it doesn't exist. And that will be recapitulated at Hampton. There's a cardiovascular project which is looking at a ecological model of intervention in behavioral change. It's a physical fitness intervention to improve the health of African-American males in 4 counties in Mississippi. Remember that Mississippi where that heart disease is. So one of these counties which we're looking at was named the fattest county, not in Mississippi, in the entire United States. And they are now number 3 because a neighboring county won them. But they again, and we have a strong community partnerships there, working with a community organization. At Hampton, we have a men's. I showed you again as homicide as being one of the big issues that cause premature death in the African American community. So violence is a big issue that we need to address within our community. So at Hampton University and Howard, there are teams working on intervention strategies to change African American men's response to anger and violence and how we respond in those areas, and that's quite interesting. And in North Carolina, A&T, they're doing work related to a number of things related to diabetes and obesity, from biomarker to, again, interfaces where the biomarkers, and those biomarkers they're looking at early detection for diabetic nephropathy as complications from diabetes, and also we're looking at intervention programs to change lifestyle there. So one of the programs I want to talk to you about is our pilot project program. And again, it's really designed for high-risk, high-reward studies that can lead to breakthroughs in reducing health disparities in minority male populations. And we're really looking for projects which will result in novel techniques, agents, methodologies, modes, or applications that will impact in the shorter term than the longer the health of these communities. So we have a significant amount of money that we left. We try to encourage exploratory projects from MSIs within regions 3 through 4, which extends from Pennsylvania down to Mississippi. And we really want to provide support for get them some early conceptual stages of the project. And again, we are trying to cultivate this transdisciplinary health disparities research model of not just a single investigator working in a silo just studying one little molecule, but we're trying to either put a series of projects together that gives us a bigger inroads and impact on a disease. It could be a subpopulation or a regional or geographic, or a bigger insight into a bigger problem. So we're trying to be strategic in doing that. And again, a lot of these projects, we're trying to keep them honed to kind of tie into the initial 4 sub-projects which we have there. Again, I mentioned that. The transdisciplinary team, I'm just going to show you, we funded our first set of pilot projects last spring, and this is just an example. We have 2 instruments. One is a seed project program, which funds $40,000 a year for 1 year, which is really a concept development, laying the foundation for doing first men's health disparities work, but also the foundation for doing these transdisciplinary collaborative models, because most of us were not taught how to do team science. Most people don't get tenure and promotion from doing team science, and institutions are responding to that. How do you reward people who are part of these You're not the first author, you're not the PI, but you're contributing to it. So again, even in HBCUs, it's the same problem. So it's a change in the culture there, so we want to encourage that. So one of the projects is leveraging a ministers conference that happens at Hampton. It's in its 101 year, and they bring together about 5,000 to 8,000 ministers to campus every summer, and there's a database of about 20,000 that they communicate with each year. And again, this project was designed to, if you can impact the leaders in the community to change their habits, their lifestyle, and their interests, could you have them be your change agents to advocate for their community to change their lifestyles? And so that's one of the seed projects we funded. This project is interesting also looking at the role of masculinity, how men perceive themselves and their view, and how racism impact on them, and how they're a predictor of obesity risk in the population that's in North Carolina. This one is pretty cool too. This is using a disease spread model of geospatial analysis of violent hotspots to, if you were to model using GIS data and crime data, could you model from looking at that data set how violence is spreading in communities? And if you can see the patterns of spread and can predict them a priori, could you go in and put in best practices of interventions before the violence spread in that area? So these are models. So Sherry Wiley is actually on a leave for 2 years at University of Pennsylvania and working with Charlie Brannis and others at Penn who does this social epidemiology kind of work. So we're pretty excited about that. In a pilot project, these are for 2 years and funded at $125,000 a year. A group from, again, at A&T is doing some additional work in diabetic nephropathy for biomarkers. Joanne Powell at Clark Atlanta is looking at androgen receptor signaling in advanced prostate cancer, which in African-American male prostate cancers tend to present later and more aggressively. And the question is whether their presence, in the same sense that we look at receptor population in breast cancer, is a receptor population milieu in prostate cancer may predispose for the aggressive nature of prostate cancer. So she's doing some work there. And Amir Sahib at Albany State is looking at an electrophoretic detector system to be able to use fragments of DNA related to specific markers in prostate cancer to be an early diagnosis of disease, and very exciting work he's doing there. So these are some of the projects we fund. I'm going to kind of stop here. What I would like to encourage is that some of you here to help us do what we are trying to do. You have wonderful technology, wonderful platforms. One mechanism is to partner with some of my people who may be currently here or some of the other institutions that we can work with and build the kind of projects that see if some of your technology could be translated, working with some of those, some of the social science guys, you work with some of the clinical guys, and define problems that address disparities in care and maybe in certain communities, or you can use it as a model. But if we can do that, I would love to have my investigators partner with you guys and translate in some of this technology. And again, the end result is that we want to eliminate and reduce health disparities. Okay, I'm going to stop there. Open up for questions.